Good evening, everybody. Welcome to this episode of Pathology Understanding for Residents and Students Pursue 3A. And today we have something very special. We have soft tissue tumors, approach to soft tissue tumors, pattern-based approach with the role of immunohistochemistry and molecular diagnostics. And to speak on this, we have with us Dr. Gude Geethanjali. She is an MD Pathology from PGI Chandigarh, and she is a DM in Histopathology from PGI Chandigarh. And she has a special distinction of being the first lady DM Histopathology in the country. Who better to speak on this topic? She is live with us from Visakhapatnam, and I would like Dr. Geethanjali to take over. Dr. Geethanjali, please share your screen. Thank you.
Thank you, sir. Sir, can you hear me loud and clear?
Yeah, you are absolutely loud and clear.
Okay, sir.
Yeah, we can see your screen. Yeah, you can start with the first slide.
Okay, sir.
Yeah,
shall I start, sir?
Yeah, before you start, let me just tell everybody, please keep your audio and video muted. And in case you have any queries and questions, you can type on the chat box. And once Dr. Geethanjali wants anybody to say something or to have any discussion, please she'll put it on the system, and then you can unmute your mic and pass your comment. Please start. Thank you so much.
Okay. So thank you for giving me this opportunity to discuss about soft tissue tumors. So soft tissue tumors is one of the interesting topic, but at the same time the most difficult and extensive, because we have over 150 types of soft tissue tumors, and each and every tumor has its own distinct morphology. And the benign tumors are much more common than the malignant soft tissue tumors. And the malignant tumors, that is the soft tissue sarcomas, are very rare. They represent 1% of malignant neoplasm. Because of this rarity, presence of several types of distinct entities, and the deceptive histomorphological attributes, that everything has a poorly differentiated kind, everything has either a spindle cell pattern or a round cell pattern. It is a very challenging diagnosis to make for all the pathologists. So this lecture, I want to just give a brief introduction to all the entities which are present and how we should approach in our routine reporting. And in further lectures, I will go from based on the individual topics. So coming to definition of soft tissue, it includes all the non-epithelial and extraskeletal tissues of the body, exclusive of the reticuloendothelial system, glia, supportive tissue of various parenchymal organs. So soft tissues includes the muscle, which is both skeletal as well as smooth muscles, adipose tissue, fibrous tissue, vascular tissue, and most of these are embryologically derived from the mesoderm. And the peripheral nervous system is also included in the soft tissue, which is the only system which is derived from the ectoderm. So in our routine practice, the types of specimen which we receive are the biopsies or the surgically dissected specimen. Most of the biopsies are either true cut or incisional biopsies. Since the clinician needs an established malignant diagnosis for a deep soft tissue tumors of more than 5 centimeters, nowadays there is an increasing approach to take biopsy of the soft tissue tumor for diagnosis. So they send us biopsies to establish malignancy and for assessment of histological type, subtype, and give grade if possible. And it is important for decisions which is regarded to the neoadjuvant chemotherapy, because sensitivity to chemotherapy and radiation depends upon the different histological types and the grades of the soft tissue sarcoma. The other type of specimen which we get are the surgically dissected specimen. So most of the time the surgically dissected specimens are easy. The dissection depends upon the location of the tumor, size of the tumor, and the subtype of the tumor. If it is located in easily accessible site like in extremities, Usually we get a proper resected tumor with adequate margins, but sometimes it may not be the case, like in case of retroperitoneal sarcomas. So the scope of excision is usually dictated by the tumor size, histological type, relation to the normal vascular structures like the major blood vessels or the neurovascular bundles. So if there are major blood vessels or neurovascular bundles present in close proximity, we may not get the adequate margins. And low-grade sarcomas and subcutaneously and intramuscularly located high-grade sarcomas, which are less than 5 centimeters located in extremities or trunk, if there is negative margins, the treatment is just surgery alone. So it is very important to comment upon the margins when we receive a specimen of surgically resected soft tissue tumor. If there is a high-grade sarcoma, which is more than 5 centimeters, they give pre or post-operative radiotherapy. Even in sarcomas which are margin positive, if we give margin to be positive, they may go for radiotherapy. And in case of retroperitoneal sarcoma, where the margin-free resection is not possible, the completeness of resection, histological grade, type, and subtype are the most important prognostic factors. So all this is to emphasize that while reporting a case, we should include all these factors in our report, like the histological grade, type, as well as the subtype. So coming to the reporting of core biopsy, so there are many problems with the core biopsy, like the tissue is not adequate, but we should make sure, if possible, to give a proper clear diagnosis and grade the tumor on the biopsy itself. We can use the ancillary techniques which are available to us, like immunohistochemistry or the molecular. And if clear diagnosis cannot be established, we should at least give a descriptive diagnosis, like it's a benign lesion or a low-grade MYXOID lesion which is favoring benign, or high-grade pleomorphic sarcoma which is not further cannot be categorized. And a descriptive comment is highly recommended in many cases, and we have to discuss the differential diagnosis so that it can be correlated with other clinical and radiological findings. So the caveats or the drawbacks of this core biopsy is, most of the times there is underdiagnosis or misdiagnosis. Underdiagnosis is when we don't get the actual tumor sample, or if the grading is not adequate, like there might be high grade and low grade areas because of heterogeneity within a tumor. So the low grade area can be sampled, which makes us miss the high grade areas. And many times there are misdiagnoses. That is because of idiosyncrasies. That means some of the sarcomas may appear low grade. They can have a deceptively bland morphology, like in case of low grade myxoid sarcoma. In case of myxoid liposarcoma, the cellularity can be very low that we think it is a benign tumor. And some benign tumors can have features which suggest malignancy. Like, it is very important to appreciate the gross architecture and zonation in case of nodular fasciitis or proliferative fasciitis, but this may be missed because only one portion of the whole tumor is sampled, where we see very atypical pleomorphic nuclear mitosis, and we may misdiagnose it as malignancy. And coming to the reporting of the resected specimen, in resected specimen, we should give a definite diagnosis and histological grade if applicable, and margin status should be mentioned in all the resected specimen. And additionally, we should also stage the tumor based on the size, and in cases which are difficult and cannot be classified, again we should attempt to give a descriptive diagnosis as a low-grade myxoid sarcoma (NOS) or a epithelioid malignant mesenchymal neoplasm, which is favoring a high-grade sarcoma. And for tumors treated with neoadjuvant therapy, we should also mention about the therapy effect. How much is the tumor viability and how much response it has been. And when we receive the specimens, before receiving the specimen, the minimal prerequisite for a diagnosis is what we expect from clinician is to give all the details possible, which must and should include age of the patient, because there are some tumors which specifically occur in pediatric age groups, like which we also call as pediatric soft tissue sarcomas, and we cannot diagnose an MPNST in a pediatric age group, or some case of neuroblastomas or Ewing sarcomas are all restricted to specific age group. And we should also know the location of the tumor, because there are some tumors which occur more commonly in some regions when compared to other regions. Tumors, the most common is liposarcomas, though other sarcomas like leiosarcomas occur. The liposarcomas most commonly occur in deep location as well as in proximal locations like thigh or retroperitoneal region. And we should also note the depth of location, whether it is superficially located or deeply located. This is especially where there is lot of atypia. If it is superficially located, we will call it as atypical spindle cell lipomatous tumor rather than a well differentiated liposarcoma in case it is deeply located. And some tumors are common in head and neck region like the rhabdomyosarcomas or hemangiopericytoma. And synovial sarcomas can occur in upper extremities or the lower extremities. In case of visceral locations, we will diagnose more commonly the leiomyosarcomas or the angiosarcomas or GIST. So we should know the specific location of the tumor. And growth characteristic is good if we know, but it is not very helpful because there may be some benign or reactive conditions which grow very rapidly. The example is nodular fasciitis, which grows very rapidly over a period of 1 to 3 weeks. So next, coming to the classification of sarcomas. So there has this recent 5th edition of WHO soft tissue sarcoma has some 12 categories, and they have classified it based on the line of differentiation into whether it is showing adipocytic, fibroblastic or myofibroblastic, fibrohistiocytic, vascular, pericytic, muscle, gastrointestinal stromal tumor. This gastrointestinal stromal tumor is newly included in the 2013 edition, which is still continued, the chondro-osseous, peripheral, and those with differentiation. So among all these tumors, again they are further categorized into those having benign potential, intermediate potential, intermediate aggressive potential. So intermediate means they can be locally aggressive or rarely metastasizing. Locally aggressive tumors can have a recurrence potential, but they don't metastasize. And the rarely metastasizing tumors usually have a less than 2% chance of metastasis. And malignant tumors, which can again be a low grade or a high grade. Low grade tumors usually have the 2 to 10% chance of metastasis, and high grade tumors have like 20 to 50% chance of metastasis. So based on biological potential, they are again divided into benign, intermediate, and malignant. And in 2020, the new 5th edition, we also have some molecular classification based on specific molecular genetics, which is specific for the tumor, which I'll be discussing in the respective entities when I discuss the tumor individually. So coming to the approach of the soft tissue tumor by the pathologist, I would like to give a kind of algorithm of how to approach to a diagnosis of soft tissue tumor. So when we receive any soft tissue tumor, first we should try to identify whether it is a reactive condition or a neoplastic condition. Is it really a tumor or is it something reactive? So this is a lesion. Can someone describe this lesion?
Somebody can
Hello?
unmute the mic and describe the lesion, please. Okay, I think you could continue.
Okay, I will describe this lesion. So if we come to this lesion, this is a mass which is present in the knee region in a 20-year male patient. So this specimen has come. We can see that this specimen is having a well circumscribed and pushing kind of margin, and there is some specific architecture to this which is called as zonation, which we should appreciate in this. So zonation is, in the center we have the cellular fibroblastic proliferation, and as we go to the periphery we can see the bone formation. So this kind of pattern is called as zonation. So we should identify zonation so that to identify the reactive lesions and differentiate it from the neoplastic lesion. So here we can see in the periphery of the lesion we have this reactive bone formation, whereas in the center it is very cellular, and it is formed by granulation tissue like stroma formed of fibroblast. There is also inflammation in macrophages. So this is a case of myositis ossificans. We should not confuse it with any ossifying tumor. So this is, since we are talking about zonation, I am showing one more example of the case where zonation is very important. So in this lesion, this is a 34-year female who has a rapid growth present over 1 to 2 weeks, and it is a 2 centimeter mass in the arm. So if we see in this lesion in the periphery, we can see presence of this skeletal muscle fibers, and this is the fascia. So we have the tumor which is present at the level of the
just change your pointer, please. Sorry. You can just put the laser pointer. Right. Thank you.
So,
Thank you so much.
Here in this tumor, we can appreciate the normal structures which are present here in the periphery, which are the skeletal muscle fibers. So while assessing any tumor, first thing we should do is look at the normal structures which are present at the periphery of the tumor or the lesion, so that we can assess the depth of the lesion at what level the tumor is present. And so this is a skeletal muscle and this is a fascia. So this is a tumor which is present at the level of the fascia. And we can see that in the periphery we have many cellular zones, whereas in the center there is more cystic hypocellular region with lot of cystic degeneration. So these are the cellular areas which has some vague storiform kind of pattern, and hyalinized blood vessels are present from where the cells are kind of emerging. In addition, we also have this ropey collagenous bundles, and background shows lot of MYXOID stroma and extravasated RBCs are present. And once we go to high power, we can also see presence of mitosis. But though mitosis is present, if we look at all these cells have a very regular nuclear membrane, and it has a very banal kind of nuclear chromatin character, which is very bland morphology, and maybe 1 to 2 nucleoli are present visible here and there. So these cells do not look atypical. All these are fibroblast. We also have few scattered inflammatory cells present. So this is a characteristic morphology of nodular fasciitis. Though I described in nodular fasciitis here as reactive versus malignant, now it is called a clonal neoplasm, and because it has this characteristic USP6 gene rearrangement with the partner gene MYH9 in chromosome 17, and it is a novel model of transient neoplasia. So once we have decided whether the tumor is reactive or neoplastic, after deciding that it is neoplastic, we should go on to see what is the biological potential of the neoplasm. That is, categorize it into whether it is benign, intermediate or malignant based on a constellation of histological features, because we cannot take a single criteria and then put it into a specific category of benign, intermediate or malignant. We should look at various factors which include the site of the tumor, the size of the tumor, the location of the tumor, at what depth it is present, superficial or deeply located, and what is the margin like, whether it is expansile, invasive or infiltrative borders, because the tumors which are more aggressive usually have an infiltrative and invasive border, presence degree of the cellularity, the pleomorphism and anaplasia of the tumor cells, mitotic figures and necrosis. In mitosis, we should look at whether the mitosis is a typical mitosis or an atypical mitosis, because a typical mitosis can be present also in the benign lesion. Now we have seen the example of nodular fasciitis where there was mitosis, but it was a typical mitosis. Typical is like a bipolar mitosis, and atypical is like asymmetric kind of mitosis, which is tripolar or ring mitosis. But though we can say these are the histological features which indicate the aggressiveness of a tumor, we can have some benign tumors which are showing nuclear atypia or pleomorphism. Like in case of fibrous histiocytoma, we can have bizarre cells. Pleomorphic lipoma also has a bizarre cells. In case of degenerated or ancient schwannoma, symplastic glomus tumors, and in cases of neurofibroma, we may find pleomorphism or atypia, but we should see all the features and then only come to assessing the biological potential of the tumor. And in some cases, like in low-grade fibromyxoid sarcoma, it has a very bland morphology, and we may not call it sarcoma, but it is into a sarcoma. So every tumor should be individually approached. So this is a case. So is there any immunohistochemistry to identify benign or malignant? There is no immunohistochemistry, and we cannot rely on Ki67 to say whether it is a benign lesion or a malignant lesion, because Ki67 is not an indicator of mitosis. We can do phosphohistone, but in certain conditions, the immunohistochemistry can be useful, like in case of whether it is a cellular schwannoma or a malignant peripheral nerve sheath tumor, we can do S100, because S100 is diffusely positive in case of cellular schwannoma, whereas in case of malignant peripheral nerve sheath tumor, it doesn't show diffuse positivity. And MPNST also shows H3K27 loss. So H3K27 is also a useful immunohistochemical marker to differentiate cellular schwannoma from a malignant peripheral nerve sheath tumor. And one more situation where immunohistain can be helpful is to differentiate dermatofibroma and dermatofibrosarcoma. Although we have the morphological features like the infiltrating border, entrapping of adnexal structures, the cellularity and everything, in case of doubt, we can use CD30 for immunostain, which shows diffuse strong positive in dermatofibrosarcoma protuberance, whereas in benign fibrous histiocytoma, shows only patchy positivity. So after identifying the biological potential, we can go on to one more important thing we should keep in mind is whether it is truly a mesenchymal neoplasm or it is a non-mesenchymal malignant tumor which is showing a morphology which mimics sarcoma, which are like mimickers are the sarcoma. The most common mimickers are the sarcomatoid carcinoma, which has a spindle cell morphology. But if we see sarcomatoid carcinoma in low power, it is so much pink-looking tumor, and somewhere we can find the epithelial differentiation, and we should always look at the overlying epithelium. If the overlying epithelium if we find dysplasia, we should favor a sarcomatoid carcinoma rather than a mesenchymal sarcoma. So we should do extensive sampling of the tumor, and the location is also important. We can find sarcomatoid carcinomas in skin, mucosal surfaces, and in viscera also we should think of sarcomatoid carcinoma without proceeding to think that it is a sarcoma. Other spindle cell lesion we should keep in differential diagnosis is a spindle cell or desmoid.
ऑफ हो गया ठीक है हमने इससे लगाया इससे क्या करना कनेक्टेड है सर
Hello.
Hello? Yeah.
Hello.
Yeah, your screen is coming.
Next is alveolar pattern. So alveolar pattern is like this is a nest of cells with cells lining the periphery of the nest and some disc cohesive population in the center of the this kind of nest is the alveolar pattern. So alveolar pattern in low power itself, it gives us clue to some specific tumors which are the alveolar soft part sarcoma. If the tumor cells are having abundant eosinophilic cytoplasm, eosinophilic to clear cytoplasm, we'll think of alveolar soft part sarcoma. In case of small round blue cell morphology or rhabdomyoblastic differentiation, we think of alveolar rhabdomyosarcoma. Next is a plexiform pattern. So plexiform is derived from the name plexus, like the brachial plexus or the lumbar plexus. It is like interconnecting strands. So plexiform pattern is seen in case of plexiform schwannoma, plexiform neurofibroma, dendritic cell neurofibroma, and also in plexiform fibrohistiocytic tumor. And this is the nuclear palisading. So nuclear palisading is a regimental arrangement of the nuclei next to each other, which is alternating with the anuclear zones, anuclear fibrillary zones. So this nuclear palisading with formation of this characteristic verrucate bodies are seen in case of schwannoma, but we should always remember a subset of leiomyomas can also show nuclear palisading, and also in a subset of gastrointestinal stromal tumors, we see nuclear palisading. And there is a tumor called as intranodal palisaded myofibroblastoma, which also shows this characteristic palisading pattern within the lymph node. And one more histological feature which helps in diagnosis is a giant cell. So hyalinizing spindle cell tumor with giant rosets is again a variant of low-grade fibromyxoid sarcoma, which shows presence of this giant collagenous rosets, which is a helpful clue in the diagnosis. And one more giant rosette is seen in case of schwannoma with neuroblastoma like rosettes. In the low power, we may think that this is like a hyalinizing spindle cell tumor with giant rosettes, but here the cells have more small round blue cell morphology resembling the neuroblastoma, and rest of the area has a characteristic pattern of schwannoma. Next, coming to the surrounding stroma, which we should look at, which are tumors with inflammatory stroma. So in this case, we can see that this is a tumor, and in the periphery, it is almost resembling like a lymph node with a prominent lymphoid stroma, and there is also germinal center formation with lymphoid follicles with prominent germinal center formation, and this is a characteristic feature of angiomatoid fibrous histiocytoma. So it is described that in low power, you feel that it is like a lymph node. And presence of inflammatory stroma should also clinch us to think of IgG4 related pseudotumor, which is a calcifying fibrous tumor, and the inflammatory myofibroblastic tumor also shows a prominent inflammatory stroma. And in case of smooth muscle neoplasm, which is having inflammatory stroma, you should think of Epstein-Barr virus associated inflammatory stroma. Other differential diagnosis is the myxoinflammatory fibroblastic sarcoma, and dendritic cell sarcomas like follicular and interdigitating dendritic cell sarcomas and fibroblastic reticular cell sarcoma. And in gastrointestinal schwannoma also we see presence of stroma with formation of lymphoid follicles, and inflammatory fibroid we have lot of inflammation, and eosinophils are very prominent in case of inflammatory fibroid polyp. Next is tumors with collagen bundles. So this is a case where we have a tumor which is present within the lymph node. It has lot of collagenous stroma in the background, and it has this characteristic palisaded collagen bundles. So this is a feature of intranodal palisaded myofibroblastoma. In addition to the collagen bundle, we see some variants of collagen. Like this is a ropey collagen, which is a distinctive feature of spindle cell lipoma. And the collagen in neurofibroma is kind of compared to a shredded carrot like collagen, which is present in neurofibroma. And in gastrointestinal stromal tumors, we see some extracellular collagen blobs like this, which are called as sphenoid fibers. They have a characteristic ultrastructural feature. So these are helpful clues in the thinking of that specific subtype. Coming to the stromal matrix, we have tumors with prominent myxoid matrix, and based upon the location of the tumor, the level of present, whether it is in dermis, subcutaneous tissue, or a deeply located, and the biological potential, we have many tumors which show prominent myxoid matrix. The benign tumors are the superficial angiomyxoma, dermal nerve sheath myxoma, ossifying fibromyxoid tumor, and we can have myxoid change in nodular fasciitis that it appears to have an abundant myxoid matrix in low power. The tumors with intermediate biological potential showing prominent myxoid matrix are the aggressive angiomyxomas and the low-grade fibromyxoid sarcomas. And the malignant tumors are the myxofibrosarcoma and also the low-grade fibromyxoid sarcoma and the myxoid liposarcomas, leiomyosarcomas, DFSP and MPNST. So when we encounter a myxoid tumors, we should think of all these differential diagnosis. And the tumors with prominent giant cells, if we see these two giant cells, the difference between these giant cells are these are the osteoclast kind of giant cells, and these are a characteristic xanthelasmic cells, foamy cells having this wreath-like arrangement of the nuclei, and these are called as two-tone giant cells. So these, if the presence of two-tone giant cells indicates that it's a juvenile xanthogranuloma, whereas tumor with prominent osteoclast-like giant cells is seen in case of tenosynovial giant cell tumor, which can be both localized and diffuse type, and also giant cell tumor of the soft tissue. But some other entities can also show giant cells, like nodular fasciitis can show presence of giant cells, but these are the tumors with predominant giant cell population. The cases where the presence of characteristic calcification gives a clinch to diagnosis is the phosphaturic mesenchymal tumor. So this is a tumor where you can see presence of this grungy calcification. Once you see this grungy calcification in low power itself, you can think of this phosphaturic mesenchymal tumor. And other tumors showing this osteoid or cartilaginous matrix in the stroma is calcifying fibrous sclerotic fibroma, myositis ossificans, and many malignant tumors can show osteoid or cartilaginous heterologous elements. So that is regarding the patterns and the architectural clues which helps us in arriving in a diagnosis. But it is not always easy like that we can see one specific morphology and go into diagnosis. We should always look at the whole picture. And now coming to the cytomorphology, if we look at the cells can have a predominant small round blue cell morphology. Then we go and think of some differential diagnosis. There can be a spindled morphology. We can have an epithelioid morphology with polygonal cells having abundant cytoplasm, epithelial looking kind of epithelioid morphology, or we can have a very pleomorphic cells with many bizarre multinucleated giant cells. And many times there is a biphasic or a mixed kind of morphology in tumors.
Doctor, so can you just press on that hide thing so that goes away? No. So, you got that thing. So yeah. Thank you. Yeah.
So based upon the cytomorphology, if we go into the small round blue cell tumors, the most common differential diagnoses include the leukemias, lymphomas, Wilms tumor, neuroblastomas, Ewing sarcomas, embryonal rhabdomyosarcomas. The round cell liposarcoma is not used nowadays. It is just myxoid liposarcomas, the extraskeletal myxoid liposarcomas, desmoplastic small round blue cell tumor, and any small cell osteosarcomas and undifferentiated round cell sarcomas. So these are the differential diagnoses you will think when you have a tumor whose cytomorphology is like a small round blue cell tumor. And I have like a huge list of tumors we should think based upon whether there are spindle cells, epithelioid cells, and pleomorphic cells. I think reading out this list is not that useful now. When we go into individual entity, then we'll get a better idea about the morphology. So when we have a tumor which is undifferentiated and shows this characteristic spindle, round cell, epithelioid, or pleomorphic type of morphology, next thing we should do is identify what is the lineage of differentiation of these tumors. This lineage of differentiation we can identify in morphology itself based on presence of adipocytic differentiation or a case of strap cells like rhabdomyocytic differentiation. But if we don't find it in morphology, we take help of additional ancillary techniques which are immunohistochemistry and molecular genetics, then go into that particular histological subtype. So immunohistochemistry, while performing immunohistochemistry, we have two components. One is the technique or the hardware component where we use the antibodies and the detection system, and the analysis by the pathologist, which is the interpretation. Both are important in case of immunohistochemistry because in case of improper technique, like in many cases based upon the CLO, we can get a nuclear expression instead of a cytoplasmic expression, which is not useful. And we should interpret in the tumor cells, not in the adjacent cells. Like S100 can come positive in many cases of dendritic cells which are present in the stroma. We should not consider it a positive. And while interpreting, we should be careful that we are seeing the positivity in the tumor cell and not in the adjacent stromal cell. And we should also see that it is coming positive as the pattern of positivity should also be seen, like membranous positivity, cytoplasmic, or nuclear positivity. For that specific immunohistochemistry we have used, or the antibody which we have used. So when to use immunohistochemistry is when we have to distinguish histologically similar tumor. Like in case of small round blue cell tumors, all look almost similar, or in case of spindle cell tumor or epithelioid tumors. And to confirm the histological impression, we can use immunohistochemistry. And to support the diagnosis of a rare tumor, support a diagnosis when the tumor is having the distinct morphology but it is present in some unusual anatomical location, or support the diagnosis when the tumor affects a patient where the age is not characteristic for that tumor. So the immunohistochemical markers which we use in soft tissue, there are markers which are very specific to a tumor, and there are markers which are not specific to that particular tumor, but they are helpful in that condition, which is the useful immunohistochemistry marker. In that condition, which is the useful immunohistochemistry marker. So the most useful antibodies which we use are the epithelial markers, which I have described previously. There are some, it is useful to identify and exclude the sarcomatoid carcinomas, and also in many sarcomas which are showing epithelial differentiation, the epithelial markers come positive. And this cytokeratin should be included in the panel in most of the spindled and pleomorphic malignant cell tumors and also in epithelioid tumors. Other epithelial marker is epithelial membrane antigen. So EMA is expressed in epithelioid sarcoma. It is very useful to identify epithelioid sarcomas, and the synovial sarcoma which shows true epithelial differentiation, and perineuronoma shows EMA positivity. So these is a useful marker in these conditions. And the neural markers which we use are S100. So S100, as I already described, it is useful for differentiating the benign peripheral nerve sheath tumors and the MPNSTs. S100 is also expressed in case of myoepithelial tumors, clear cell sarcoma, which is like a soft tissue counterpart for melanoma, extraskeletal myxoid chondrosarcomas, but we should see that S100 shows unexpected positivities in also many other tumors like synovial sarcoma. And next, the tumor markers to identify the muscle differentiation. So the muscle markers are the smooth muscle antigen or smooth muscle actin. So smooth muscle actin is not very specific. It is positive in both the smooth muscles, but myofibroblast can also show focal positivity, and the positivity is shown like a tram track kind of appearance. And desmin is positive in rhabdomyosarcoma, and it can also come positive in case of smooth muscles. And caldesmon is a marker which is specific for the smooth muscles and doesn't come positive in case of skeletal muscle or myofibroblast. And we have some specific transcription factors which I'll describe in the lineage specific markers for the skeletal muscle, which are myogenin and myod1. And we have some markers which are useful in case of useful vascular markers to identify vascular tumors. CD31 is the most specific and expressed in 95 to 100% of the benign and malignant vascular tumor. And the expression of CD31 by macrophages is a pitfall. So while interpreting, we should be careful that we are looking at the tumor cell and not the macrophage before calling CD31 positivity. And CD34 is expressed in all vascular tumors, but CD34 is also positive in many other mesenchymal tumors, which are this newly described superficial CD34 positive fibroblastic tumor, mammary type myofibroblastoma, dermatofibrosarcoma protuberans, solitary fibrous tumor, spindle cell lipoma, gastrointestinal stromal tumors, and epithelioid sarcoma. So these are the list of tumors where you can see CD34 positivity. So based on this useful markers which cover the some of the tumors broadly, the basic panel we can include based upon our differential diagnosis. So we can include cytokeratin to exclude the sarcomatoid carcinomas, followed by S100 which will detect the melanomas as well as the neural differentiation, and actins and desmins for the muscle differentiation, CD34 for vascular and other broad differential diagnosis. And in case of pleomorphic tumors, we can also include CD30. So these are the basic immunohistochemical panel we can use to narrow down the differential diagnosis which we are thinking of. Followed by this, based upon the expression, we can use a lineage restricted transcription factor. So the lineage restricted transcription factor for skeletal muscle or rhabdomyosarcomas are myogenin and myod1. Apart from identifying the rhabdomyosarcomas, this myogenin or myod1 are also specific to the subtype. Like the embryonal rhabdomyosarcomas is most commonly positive for myod1, whereas the alveolar rhabdomyosarcoma is common for myogenin. So while putting the IHC, we better correlate the HNE and then put the IHC rather than blindly putting myogenin or myod1. Based upon the pattern, we can choose. And for angiosarcomas, the endothelial cells show positivity for FLI1 and ERG. And the SOX10 is the lineage specific transcription factor for neuroectodermal origin for malignant peripheral nerve sheath tumors. And melanomas are also positive for SOX10. And brachyury is the lineage restricted transcription factor for chordoma. And SAT-B2 identifies both colon cancer and the osteoblastic differentiation, so it is useful in osteosarcomas. And there are some specific protein correlates of the genetics which are helpful in identifying a specific tumor. Like nuclear expression of beta-catenin is seen in desmoid fibromatosis. We see loss of nuclear staining for H3K27, Me3 in MPNST. And in epithelioid sarcoma, where we see positivity for EMA and CD34, INI1 is like a more diagnostically definitive immunohistochemical marker where we can see loss of nuclear staining. And INI1 loss is also seen in malignant rhabdoid tumor and epithelioid MPNST. And MDM2 and CDK4 are very useful in diagnosing well differentiated and dedifferentiated liposarcomas, but not in other liposarcoma like myxoid liposarcoma. And loss of succinate dehydrogenase is seen in this succinate dehydrogenase deficient GIST and also in SDH deficient leiomyomas. And we can also have antibodies which are directed against the products of translocation. like ALK for inflammatory biofibroblastic tumors. And we have this new Ewing sarcoma-like tumors, which are the BCOR and CIC ducts for translocation-related tumors, where we have the BCOR IHC. BCOR loss will be appreciated in those tumors. And epithelioid hemangioendothelioma, which has CAMTA1 gene fusions, we have CAMTA1 IHC. And cyclin B3 is there in BCOR, CCNB3 translocated sarcomas. And other specific products of translocation like FOSB gene is there for pseudomyogenic hemangioendothelioma. And STAT6 is very useful in case of solitary fibrous tumor, because solitary fibrous tumor is positive for CD34. If we consider a differential diagnosis between solitary fibrous tumor and spindle cell lipomas, because many of the solitary fibrous tumors, we also have a subset where there are fat forming solitary fibrous tumor. In that scenario, STAT6 is a very useful immunohistochemistry marker. And in translocation associated sarcoma like alveolar soft pod sarcoma, TFE3 immunohistochemistry is very useful. And other one which are discovered during gene expression profiling are DOG1, MUC4, which comes positive in low-grade fibromyxoid and sclerosing epithelioid sarcoma, NKX2.2 in Ewing sarcoma, and TLE1 in synovial sarcoma. So I know this is all very confusing right now, but once we approach every tumor one by one, you will get more clarity. So this seminar is just to introduce you to all these entities. So apart from the immunohistochemistry, we also have molecular diagnostics for diagnosing a specific soft tissue sarcoma. So the molecular diagnostics are more specific and more useful than the immunohistochemistry. So the soft tissue neoplasms have two major groups of genetic abnormalities, the ones which are associated with complex karyotypes and the ones which have recurrent chromosomal structural abnormalities, gene amplifications, mutations, or loss of heterozygosity. So it is difficult to identify the one with complex karyotype, and these, the later category, which are having recurrent chromosomal structural abnormalities, gene amplification, mutation, and loss of heterozygosity, are used in protein molecular testing. So the methods of detection which are most commonly used in the clinical practice are the fluorescence in situ hybridization, where we can use for rearrangement, and the reverse transcriptase PCR, where we can see the presence of fusion product as we read as a base pair, and amplification curves in RT-PCR. When there is a differential diagnosis of small round blue cell tumors, the differential diagnosis morphologically we have are the Ewing's family of tumors, alveolar rhabdomyosarcomas, neuroblastomas, and desmoplastic small round blue cell tumor, myxoid liposarcoma, and the polydifferentiated synovial sarcoma. This family of tumor, this Ewing sarcoma has a typical translocation which affects the chromosome 22. So in chromosome 22 is a family of ETS transcription factors, and in 90% of cases, chromosome 22, the ETS transcription factor, which is EWSR1, partners with chromosome 11, producing a fusion transcript of EWSR1 FLI1, and the less common transcription factor is chromosome 21. So in case of Ewing's family, we have a lot of fusion partners with EWSR1, and we also have fusion partner with FUS, which is again an ETS family of transcription factor. But the problem is when we use the EWSR1 probe for detecting the gene rearrangement, there are many other tumors which have a similar EWSR1 gene rearrangement, but the partner is different. Especially in case of this desmoplastic small round blue cell tumor, which is a differential diagnosis in the round cell sarcoma. It also has this EWSR1 gene rearrangement, but the gene partner is WT1. So in these cases, we should go for RT-PCR to identify the fusion transcripts rather than going for the FISH for detecting EWSR1 rearrangements. only in cases where the differential diagnosis is clinching and both of them have EWSR1 gene rearrangement. And the other alveolar soft rhabdomyosarcoma has translocation of 213 and 113 of FOXO1A gene with PAX3 and PAX7. And this alveolar RMS, apart from diagnosis, it is also prognostically useful and also useful for the risk stratification because presence of gene rearrangement with FOXO1A is associated with poor prognosis. And in poorly differentiated sarcoma, we have this characteristic translocation X18 between SS18 and SSX1. But for synovial sarcoma, we have this static immunostain, which is very useful. So these are the gene partners for EWSR1, and Ewing sarcoma also has translocations with FUS. These are the differential diagnosis these are the tumors which have the EWS gene rearrangement with these partners. And in Ewing sarcoma, the most common partner is FLI1, followed by ERG. In desmoplastic tumor, the fusion partner is WT1. In myxoid sarcoma, we have DDIT3. So we can use a FISH probe for DDIT3. In clear cell sarcoma, ATF1. In extraskeletal myxoid chondrosarcoma, we have TEC. So similarly, we can take help of molecular genetics while assessing the lipomatous tumor. Most of the time, we don't, for lipoblastoma, it is morphologically we can make the diagnosis. We don't need the molecular genetic study. If we need, we can do a FISH with PLAG1 gene. And chondroid lipoma most commonly comes in differential diagnosis for myxoid chondrosarcoma. In that case, we have C11 of 9, and myxoid chondrosarcoma has DDIT gene translocation with EWSR1. So in that scenario, molecular genetic is helpful. And in atypical lipomatous tumor, we have MDM2 amplification as well as CD4 amplification. This is also seen in dedifferentiated liposarcoma. And in skeletal muscle tumor, as I already said, this alveolar rhabdomyosarcoma, the translocation with FOXO1 gene has a poor prognosis. So it is also useful for risk stratification and prognostication. And epithelioid hemangioendothelioma has WWTR, CAMTA1 and YAP1 TFE3 gene rearrangement. In the new WHO classification, they have named epithelioid hemangioendothelioma along with this characteristic gene rearrangement. And in other spindle cell tumors, we can go for the rearrangement in case of differential diagnosis. And ETV6 NTRK3 is a characteristic rearrangement which is seen in congenital or infantile sarcomas. We have new emerging NTRK rearranged sarcoma as an emerging entity in the new WHO. And in low-grade fibromyxoid sarcomas and sclerosing epithelioid fibrosarcoma, we have FUS gene rearrangement. Even immunohistochemistry MUC3 is available for these tumors. And in tumors of uncertain differentiation, in synovial sarcoma, we have this characteristic X18. In epithelioid sarcoma, there is loss of IONI1. Genetically, it has MARC-CB1 gene mutation. And alveolar soft part sarcoma has AS-PSCR1 and TFE3 gene rearrangement. We can use IHC of TFE3. And in clear cell sarcoma, again, we have EWSR1 gene rearrangements. And in extraskeletal myxoid chondrosarcoma, the most common gene rearrangement is EWSR1 with NR4A3. So using all these patterns, immunohistochemistry and help of molecular genetics, after we come to a specific histological subtype diagnosis, if it is a sarcoma, we should further grade the sarcoma and also give a stage for the sarcoma. So we have this different grading systems, which is the Marquis Jensen's grading system and National Cancer Institute. The most commonly followed one is the French Federation of Cancer Center Sarcoma Group, which is FNCLCC. It has 3 parameters. One parameter is based on the tumor differentiation, like how closely it is resembling the normal adult tissue. And it is given a score of 1, 2, and 3, and mitotic count, and followed by tumor necrosis. So totally, it is graded into grade 1, grade 2, and grade 3. This is important because higher grade tumors have a higher chance of metastasis, and so they give grade 1 tumors have 2 to 10% chance of metastasis, whereas grade 3 have 30 to 50% chance. So if we give a higher grade, they give an adjuvant radiotherapy or chemotherapy based upon the histological subtype. And we should also stage the tumors by tumor size, the TNM staging. If we know the status of the regional lymph nodes and metastasis, we can give the N and M parameters, but we should give the PT stage while reporting a soft tissue sarcoma, the resected specimen of a soft tissue tumor. Thank you. So in the upcoming class, we'll see about, we'll have a lecture about soft tissue tumors with fibroblastic and myofibroblastic differentiation, the smooth muscle, skeletal muscle, and nerve sheath. All these are mostly the tumors which have a spindle cell morphology. So I have kept all this together. Thank you.
Thank you, Dr. Geethanjali. Wonderful presentation. Excellent. And let's open it up for discussion. If anybody wants to ask any question or any clarification, please unmute your mic and you can ask Dr. Geethanjali straight away. We had some little bit of hitch here and there with internet and screen sharing. I think that is part of the thing. Excellent presentation. Dr. Manoj is saying we had an excellent presentation.
Sir, can I ask one question?
Yes, please go ahead.
Geethanjali madam, excellent presentation. I have just one query. In some soft tissue tumors have a heterogeneity. So how do you approach this in a needle core biopsy? Because there are heterogeneous areas in the soft tissue tumor. So how do you address this issue in core biopsies?
So that is the one pitfall which I discussed, that because of heterogeneity, we may have underdiagnosis or we may have misdiagnosis. So we should take help of the additional molecular genetics or the immunohistochemistry if they are applicable. So mostly genetics is helpful in identifying, like grading is certainly difficult in case of core biopsies. But if we want to look at the specific histological subtype, we can use molecular genetics.
Thank you, madam.
Anybody else would like to ask anything? Dr. Manoj has been very supportive in trying to set the things in place. So nice of you, Dr. Manoj. Thank you so much. Anybody else would like to ask any question? Like we have people on YouTube also, I mean, who are watching. And this entire presentation, we had some hitches in between. So we will edit the entire presentation and we will upload it on YouTube so everybody can see it again and again, because it was very extensive. And I think Dr. Geethanjali must be very tired. And we need to see this again and again to understand the pattern approach of soft tissue tumors, which is very essential. Before we go.
There is an article in Modern Pathology 2014 where they have addressed this, how to use the ancillary techniques when diagnosing the limited core biopsy. I can share that article.
Oh, fine. So next time we will share that article and Dr. Manoj can